Good afternoon, ladies and gentlemen. My name is Garrity, and I'm extremely honored to be here today to talk about risk stratification in Brugada syndrome at the Hellenic College of Cardiology. So I'm very grateful to Professor Alexopoulos and Dr. Letzes for the very kind invitation today. So the talk, I'm going to focus on three main aspects. So the first is to provide an overview on the risk stratification problem in Brugada syndrome. Secondly is to review the clinical and electrocardiographic parameters that are important for risk stratification. And finally, I would like to report on some of our progress on the development of multiparametric risk scores in collaboration with Dr. Letz's team, and also the scores created by other groups. So Brugada syndrome, as we all know, is an inherited angiopathy that's a characteristic Brugada pattern. So the problem for physicians and cardiologists is that the patients are at different risks of adverse events, and risk stratification can be difficult, and it is difficult, especially in the intermediate risk subgroup. So there are certain patients that we already know are high risk, and they definitely need an ICD. So those are patients that have presented with prior VTVF or aborted sudden cardiac death. But there are also patients with low risk features. So, for example, if they have no prior VTVF, they have only a type 2 Brugada pattern, or they have no symptoms such as syncope. And really, the great difficulty is what happens and what do we do with the patients who are at the intermediate risk subgroup. So we made use of the data set that was available in Asia, because the advantage of having a high disease prevalence there, and with particular the Hong Kong cohort that we're going to describe in further detail, there was also very good follow-up data and linkage of data across the public sector. So, for example, if a patient comes into one hospital with Brugada syndrome and then subsequently gets discharged and then readmitted to another hospital, then that record can be retrieved and all of the clinical details are retrieved as well. And also, for example, all of the ECGs that are taken from different hospitals are also uploaded in the same central system, so we can retrieve that as well. We also leverage our collaborations with multidisciplinary teams, not only including medicine, but also including engineering and also data science. So currently, what is the recommendation for ICD implantation for primary prevention? So these are patients who have never experienced arrhythmic events. So initial risk stratification is based on the presence of syncope of cardiac or arrhythmic origin. So if you've got prior cardiac syncope, it's a class 2A indication, as we all know, whereas it's a little bit more complicated for patients who have no cardiac syncope. But if they've got a spontaneous type 1 ECG pattern, then it is recommended that we further look for other risk markers, such as bradycardic complications or the presence of sinus node dysfunction, electrocardiographic abnormalities such as those reflecting abnormal depolarization and repolarization, and genetic testing or family history as well. So at the moment, PVS, so programmed ventricular stimulation, is suggested as a further risk stratifier. So if you've got positive VTVF, then it's a class 2B indication for ICD implantation, whereas if it's negative, then it is recommended for closed follow-up only. So clearly this scheme is not perfect, because there are patients that have a spontaneous type 2 pattern only, but they do suffer from arrhythmic events. And there are patients with a negative EPS, PVS, but nevertheless go on to developing arrhythmic events. So in terms of symptoms, so the type of syncope matters. So overall, syncope is associated with a fourfold increased risk of arrhythmias, but neurally mediated syncope is thought to be more benign in cardiac syncope. So we do need very detailed information surrounding the syncope events, so any prodromal symptoms suffered by the patient, any precipitating events, any witness or patient's own accounts of the recollection of the events. And also there is a possible role for intense rhythm monitoring using implantable loop recorders. So asymptomatic cohorts is problematic. So it was previously thought that these patients to be at low risk of sudden cardiac death, but a recent study has found that 7% of these patients do go on to suffer appropriate ICD shocks over a 10-year period. In terms of ECG pattern, spontaneous type 1 Brugada pattern is a high-risk feature, as we all know, but in terms of the sensitivity of picking this spontaneous pattern, it does change with the lead position. So if you place the ECG leads higher up into intercostal spaces, then you do increase the sensitivity of picking up type 1 pattern. Also, spontaneous type 1 ECG plus syncope is high risk, whereas spontaneous type 1 with asymptomatic is relatively low risk, but it's not zero risk. And we do also want to ask the question, is drug-induced type 1 pattern always a low risk feature? And really the answer is no. So these are the summary of patients from different cohorts that have reported cardiac arrest as a presenting features. You can see that around 11% of the Italian cohort had drug-induced type 1 pattern in these patients, whereas in the other cohorts, such as Brugada cohorts, slightly lower. So, but it's still not insignificant. So, for example, here 14% have a drug-induced type 1 pattern on them, but nevertheless have cardiac arrests in initial presentation. So in terms of program veterinary stimulation, there is a lot of heated debate, and it really boils down into the patient selection criteria and also how aggressive the stimulation protocol is. So with a high number of extra stimulus, you might pick up additional patients who are VTVF positive, and also the location of the stimulation is also important. So in terms of high-risk ECG markers, so there are a number of depolarization, repolarization markers that can be high-risk features. So for example, positive R wave, so ABR sign here, fragmented QRS reflecting increased dispersion of conduction, the presence of early repolarization pattern in the peripheral leads, the presence of S wave in lead 1, and also prolonged QRS reflecting slowed intraventricular conduction, and also prolonged QTC and TVT and intervals reflecting increased repolarization times and also increased dispersion of repolarization. So in terms of clinical risk scores for stratification of arrhythmic risk, so we do tend to lump together patients who are at intermediate risk, but these patients are not the same. So the problem of the risk has been partly but not fully addressed by the development of risk scores, as we shall see a little bit later. And not all of these scores have been externally validated. So this is an overview of the various scores. So these include the major scores that have been published in the literature. You can see here there is a great disparity in the variables selected. So this is an example risk score from the UCL group in London, UK, where they looked at the spontaneous type 1 Brugada pattern, syncope, type 1 ECG, and also early repolarization pattern in peripheral leads, and they created a score system showing that there is non-linear increase in the arrhythmic risk as the risk points increase from 0 to 45. So we recently also produced a risk score, a rather simple risk score in collaboration with our our colleague from Wuhan and also the USA, where we looked at age, ethnicity, family history, and TBT and interval, and we showed that the AUC is around 0.89, where we include 4 of these risk factors. So in terms of what we achieved using the local Hong Kong cohort, our teams looked at the genetic basis of Brugada syndrome, and we also looked at the use of multiparametric approach to improve risk stratification. We also showed that serial ECG testing can be helpful because higher temporal variability in the visit-to-visit variability of ECG risk markers can be associated with higher arrhythmic risk. So there is a difference in the events between pediatric and adult presenters, and we also looked at automated ECG data and also the application of machine learning methodologies for improving risk stratification. So in terms of what we have shown in Hong Kong, so initially we stratified the groups based on initial presentation. So asymptomatic is the lowest risk group. The syncope is the intermediate risk group, whereas prior VTVF has the highest risk of future arrhythmic events. So we took the cohort one step further and validated the existing risk scores and also created our own score. So the cohort included around 550 patients. Around 12% of these patients had VTVF on follow-up. So we validated these scores because these were the scores where they include the parameters that we had analyzed in our cohort as well. So the Sierra, Shanghai, Brugada risk, Okamura, Lexus, and the D scores. So when we looked at the performance, we actually found that the Sierra score had the highest predictive value of with an AUC of around 0.81, followed by the Shanghai score and the remaining scores. So what we did was, to create our own score, we used the best performing score, which is the Sierra score, and then we added the variables that were significant on univariable Cox regression. And these were the presence of other arrhythmias, so atrial tachycardia and fibrillation or flutter, SVT, as well as sinus node dysfunction. We also included early repolarization pattern in peripheral leads, the presence of ABR sign, S-wave in lead 1, and QTC longer than 436 milliseconds. And we found that the AUC was significantly improved to around 0.86, and you can see that the ROC curves here, so the best performing scores on the top left panels. But really the major problem is the intermediate risk subgroup. So you can see that automatically all of the scores had their performance lowered if we only included the intermediate risk subgroup. So for example, our score, the AUC dropped from 0.85 to 0.7, the Sierra score AUC dropped from 0.8 to 0.57. So there is definitely still a lot of work to be done for the intermediate subgroup population. So in terms of the future work, we hope to incorporate electrophysiological findings from mapping. So this is a very nice paper from Dr. Letz's, where he showed that the conduction defects in the electrograms can also reveal the risk, and also we hope to incorporate genetic findings as well. So for example, different genetic variants produce phenotypes of varying severities. So we do hope that polygenic risk score can be included as well in the future. So in terms of opportunities for international collaborations, so we are leading this Brugada ECG indices and registry consortium. So it started off as a single study, and we were collecting cases from other centres. So Dr. Letzis was one of the first investigators to join us. We now have around 1,500 cases from 43 centres of coming from 21 countries. So I'll definitely invite you all to join us. So we're happy to include any number of Brugada syndrome or Brugada pattern cases, as long as they have ECG measurements, clinical characteristics. So other investigations such as PVS are optional. So if you do have it, it would be great to have these as well. But the most important is to have spontaneous VT-VF as an outcome. So if you would like to see the protocol or further details, please do get in touch with me during the meeting or drop me an email here. So in conclusions then, ladies and gentlemen, so hopefully we've convinced you that a multi-parametric approach is the best way forward for risk and stratification in Brugada syndrome, but this approach is not perfect. The most difficult subset is those who are at the low or intermediate risk. Because sudden death is a very traumatic experience for family members, even low or intermediate risk is very significant because the event is terminal. And there are many risk scores that are available, but only a handful have been externally validated. And there's definitely a role for machine learning algorithms where we can look at the high dimensional features and interacting features between the risk variables, all of which can further improve the predictive values of existing scores. So I just want to leave you with some thoughts on what is the risk, acceptable risk to bear for our patients. We'd like to acknowledge our team members and also collaborators. So Sharon, Christian, Keith were the original students who built the Hong Kong cohort with me, and also Angel has been instrumental in analyzing the automated ECG features from the raw ECG files, and Zhen Dong, our data scientist, who applies machine learning to our data sets to further improve risk stratification. So we'd also like to thank the local collaborators and also overseas collaborators, so Dr. Letzis in particular, who very kindly share his cohort of patients, and also investigators from Japan, China, and also Germany as well. And so very happy to take any questions. I would like to thank you all for the attention.